Dougie is a second year Master of Science in Kinesiology student, and he is at Lakehead University. And he's working under the direction of Dr. Ravanelli, who's one of our Crush researchers. So, Dougie, if you're ready, I will let you take the floor and introduce what you're going to be talking about today.
All right, sounds great. Thank you for the introduction. Oops. So I'd just like to start by thanking Dr. Dorman, of course, and Allison for the introduction, not to mention Krosh for putting the conference together and the opportunity to present our lab, the Lakehead University Environmental Physiology Lab. Some work we've been doing. So like Allison said, I'm Dougie Newhouse. I'm a second year master's student studying thermoregulation under Dr. Ravanelli up in Thunder Bay, and I'll be presenting to you a study we just completed in the summer on whether or not the oral ingestion of diphenhydramine diphenhydramine, you guys probably more commonly known as Benadryl, alters thermoregulatory responses during exercise in a warm environment. So I'll just start with a little bit of an agenda, everything we're going to be talking about. I'll start with a little review of literature, just the basics of human thermoregulation and the relevant topics to our research question before getting into our methodology, so the actual experimental design that we used. Then I'll hop into our results, our conclusion, and some future directions for research. So starting with our review of literature, humans sit comfortably at around 37 degrees Celsius, plus or minus a couple degrees. And obviously we have to tightly regulate shifts in this temperature if we want to stay alive. So there's obviously two ends to that spectrum, but for the purposes of this presentation, we're going to be focusing on the hot end of the spectrum. So just to get everybody a little bit engaged off the start, I've decided to incorporate a little brain teaser. So can anybody name the two physiological mechanisms by which human beings increase body heat dissipation under heat stress? A little poll there. Emphasis on the physiological aspect. All right. So it looks like mostly everybody got it. The answer is just on the next slide here. If you answered sweating and cutaneous vasodilation, which is a fancy way of saying increased skin blood flow, you'd be correct. Those are two physiological mechanisms to dissipate heat, and those are termed our thermoeffector responses. There's a little bit of a curveball in there, removing clothing. It's actually a behavioral mechanism. So how do we control thermoeffectors during heat stress? Well, we do so through a negative feedback loop in the autonomic nervous system. So starting with the afferent sensation of heat that happens either peripherally or deeper in our viscera. But any changes in that temperature are sensed by afferent thermoreceptors. They transduce that information up to the brain. An appropriate physiological response is then transduced down to end organs, easier thought of as just sweat glands. So this next slide here takes a little bit of a deeper look at that fourth stage in the cycle there, our end organ. So if we start on the left here, we can see an efferent signal from the brain entering a sympathetic axon that interfaces or innervates a sweat gland. So we can see that nerve impulse continue to the end of the axon, causing a release of a neurotransmitter, in this case acetylcholine, that binds to muscarinic receptors on the sweat gland, and then we end up with cutaneous vasodilation and sweating in a typical scenario. If we were to plot our typical thermoregulatory response to heat stress, it would look a little bit like this. So your body temperature increases past your sweating onset threshold, and then increases until it reaches a steady state or a max output. And I always like to include this because if something were to impact human thermoregulation, it would be apparent on this graph. So just for example, a medication or a condition or whatever delays your sweating onset, flattens the slope of your thermosensitivity or reduces your max sweat output, A, B, and C, all things equal, you would lead to higher core temperatures over the same bout of heat stress. So let's say your thermoeffector responses were inadequate. You might end up with heat illness or injury, so collectively termed HRI. So HRI is spectrumized. Milder forms might be heat exhaustions characterized by fatigue, cramps, or dizziness. More severe cases like heat stroke, characterized by confusion, changes in behavior, seizure, coma. Clinically, it's characterized by a rectal temperature exceeding 40 degrees Celsius. And at these dangerous temperatures, people can expect to get organ damage, neurological deficits, without mentioning death. And it's quite a prevalent condition. Just a few stats here I'll ring off. From 2008 to 2014, OSHA reported about 109 heat-related deaths in the US. From 2009 to 2017, about out of 571 work-related deaths in Nepalese workers in Qatar, this was largely the build-up to the 2022 World Cup. Out of 571 work-related deaths in Nepalese workers, they faced terrible working conditions. Up to 200 of them were said to be from unmitigated heat exposure. And then lastly, that last point there, from 2001 to 2004, heat-related illness or injury accounted for about 21,000 hospitalizations in American emergency departments. So it's obvious that even non-fatal cases of heat-related injury or illness can definitely stress our healthcare systems. And so some risks and contributing factors. So kind of alluded to it, but high temperature, high humidity environments coupled with strenuous physical activity would probably be the biggest two. However, some sort of lower contributors to risk would be aging, low fitness, high BMI, dehydration, or being unacclimatized. Without mentioning, and this is a little bit of a segue, supposedly certain seasonal medications. So some of these seasonal medications include antihistamines. So there's several public heat health advisories that advise against taking antihistamines whenever it's hot outside. And some of these organizations include the WHO, World Health Organization, the Occupational Safety and Health Administration, the National Institute for Occupational Safety and Health, American College of Sports Medicine, and the National Athletic Trainers Association. So the sort of rationale they're going off of is that antihistamines reduce sweat output and increase susceptibility to HRI. So if we're not able to dissipate heat, our core temperature is just going to keep going up in a bout of heat stress, and then we'll be much more susceptible to any heat-related injury or illness. But how could over-the-counter antihistamines such as diphenhydramine increase heat-related injury risk during hot weather? Well, the sort of in theory, the suspect is a mechanism of most antihistamines, which is M3 muscarinic antagonism. So we're going back to our little synaptic cleft here. And if we follow from the left, our efferent signal entering the sympathetic axon and then causing our acetylcholine to be released. But now we have diphenhydramine, or more specifically, the active ingredient diphenhydramine, blocking M3 muscarinic receptors on the sweat gland and causing decreases in sweating. But does any scientific evidence actually support M3 muscarinic antagonism, a mechanism of over-the-counter diphenhydramine, to blunt the human sweat response? Well, the answer to that is not really, but we can kind of give some insight to it. So there's two non-human studies that have demonstrated a muscarinic affinity from diphenhydramine in rats and guinea pigs, but obviously that doesn't really give us any info. Well, some, but the same cannot be conclusively said in humans. But some human studies offer some insight as well. So there are studies on Parkinson's patients suggesting that diphenhydramine reduces sweating. However, they use extreme doses, so nothing that would ever be available over the counter. Just for context, extra strength Benadryl is about 50 milligrams taken orally. And without mentioning, Parkinson's is highly comorbid with sweating impairment. So that's a big confounding variable there. One study suggested that diphenhydramine affects skin conductance, but skin conductance isn't exclusive to sweat gland activity. It's more a measure of just the moisture in your skin at a given moment. There's a single case report of diphenhydramine suppressing facial gustatory sweating in a man with facial trauma. But gustatory sweating is a reaction to capsaicin, which is the spicy ingredient in spicy foods. And it doesn't really have anything to do with thermoregulatory sweating, which would occur during heat stress. So because there's different mechanisms behind it, it's not generalizable. And then lastly, the last point there is some workers' compensation claims for heat-related injury or illness have listed antihistamines under co-occurring substances or possible contributors. Sorry, I think my audio just cut out for a second there. Sorry, this isn't really evidence because correlation doesn't equal causation. The fact that some people have had toxicology reports after HRI with antihistamines in their system isn't all that surprising when you consider that allergy season directly superimposes the hottest times of the year. So the bottom line is whether over-the-counter diphenhydramine or antihistamines taken as recommended alter thermoregulatory responses during heat stress remains largely unclear. There's two kind of large knowledge gaps that exist here. We're still not sure if diphenhydramine alters sweating during heat stress at manufacturer recommended doses, so over-the-counter doses. And we're still not sure if it affects non-clinical, or sorry, the same could be said in non-clinical populations. So no studies have been done yet in young, healthy adults. So there's a clear disconnect here that exists between the advice that public health authorities are giving and the information that's available in relevant scientific literature. But why does this all matter? From a primary prevention perspective against HRI, advising against antihistamines makes perfect sense. Nobody dies from allergic rhinitis. A lot of people die from heat-related injury. However, it doesn't consider all the implications of advising against antihistamines. So earlier I just said that allergy season directly superimposes the hottest times of the year. So therefore, advising against antihistamines would affect a lot of people. So I can be a little bit more specific and say allergic rhinitis affects 1/4 of Canadians. However, these numbers are said to be underestimates, just based on the fact that inherently people with milder symptoms will be less likely to report those symptoms. And it's a highly, highly comorbid disease with other respiratory conditions, which essentially just muddies the waters in terms of diagnosis. And the individual and economic impact of allergic rhinitis. So starting with the individual can experience congestion, rhinorrhea, difficulty breathing, general discomfort, and fatigue. And so that can obviously affect social life, productivity, and academic performance, to name a few things. And then so some insight on the economic impact. One Swedish study estimated about $2.7 billion in yearly losses due to decreased employee absentee, or sorry, an increase in employee absenteeism, decreased productivity. And then so you guys probably guessed this, but how do people treat allergic rhinitis? But people often self-medicate with over-the-counter antihistamines such as diphenhydramine or Benadryl. Over-the-counter antihistamines were the most popular form of treatment for US adults in 2017. There's some reasons for that: product availability, brand longevity, and relatively low costs. And researchers also predict that anthropogenic climate change will increase the prevalence of allergic rhinitis and thus the demand for treatment over the coming decade. So we're left with a few questions that we can go from different perspectives at. So as a society, in an increasingly warm and allergenic world, how are we going to maintain productivity if we can't take the drugs we require to remain productive? As a researcher, I'd like to know if diphenhydramine taken at recommended doses has enough muscarinic affinity to influence thermoregulatory responses during exercise in a hot environment. And as an individual, I actually cut lawns in the summer, so this hits home to me, but I want to know if it's safe for to take my allergy medication when it's hot outside. So this leads us to our purpose. So our present study was to assess whether oral ingestion of 50 milligrams of diphenhydramine, the extra strength dose, alters thermoregulatory responses during exercise in a warm environment. So we need this information if we want to best inform our public health guidelines. And so here I'll just add in, because I'm sure this will be a question later, but how did we land on diphenhydramine or Benadryl, even though if you're someone that regularly takes antihistamines, you probably know that there's better alternatives that are non-drowsy, second generation engineers. Well, one of the reasons is just because it's maintained its popularity. It's quite cheaper than most second generation antihistamines. And then two, which is sort of the bigger reason, is predictably so the studies on rats and pigs that I mentioned earlier rank diphenhydramine higher than most other antihistamines in terms of muscarinic affinity. So we're not sure, we can't say this for sure, but if out of those over-the-counter antihistamines, if one of them was going to have an effect on sweating output, it would probably be Benadryl. So that's sort of the rationale we were going off of with that. But I'll start getting into our methods, so the actual experiment here. So starting with our participants, so we had 20 participants, sex balance, so 10 male and 10 female. I won't go through all of our inclusion criteria just in favor of time, but I can pull this up later if anybody wants. So looking at our experimental design, we utilized the randomized double-blind crossover clinical trial, and sort of the illustration on the right there kind of accentuates that. So starting on the right, we have our study design. We incorporated 2 study arms, so a placebo and a drug. And each participant completed both study arms in a randomized fashion. So everybody went through and they got one trial where they had Benadryl and one trial where they had placebo, but it was randomized in which that occurred, and they were blinded to it. So after ingesting either placebo or Benadryl, they waited for 2 hours so that the Benadryl reached peak blood concentration levels. And then we threw them on the treadmill. We told them to exercise at a fixed rate for 60 minutes. And the ambient conditions in the room were about 30 degrees Celsius and 30% humidity. And then on the left there, we have our different measurements that we took over the course of every trial. So in blue, we have all of our thermoregulatory variables or measurements. And in purple there, we have our perceptual measurements. So because Benadryl is a first generation antihistamine and causes sedation, it crosses the blood-brain barrier. So we wanted to have some insight on whether our participants were just experiencing the heat that they're subject to a bit differently. So we decided to incorporate those perceptual measures as well. This next slide is our setup. So this is an actual trial on the left here. You can see our participant on the treadmill there. He's hooked up to all of our measurement equipment. And then on the right, we have just a little infographic that has all of our different placements for our measurement equipment. So you can see our VO2 mask, ECG electrodes. That's how we got clean measures of blood pressure and heart rate. And then so our ventilated sweat capsules, that's how we measure sweat rate, and then skin temperature thermocouples. So another little brain teaser here. I'll give everyone the opportunity to put on your researcher hats and sort of guess our results. And so during 60 minutes of treadmill exercise in a hot environment, do you think that the ingestion of Benadryl would cause any change in thermoregulatory variables, the way that our participants perceived the heat they were experiences, both of those or none of those? All right. Looks like the results are in. Oh, mostly everyone's thinking all of the above there. All right, so we'll have a look here, getting into our results. So starting with sweating onset and thermosensitivity. So we have sweating onset on the left. You'll notice we didn't see any differences across our placebo and drug trials for when sweating started to occur during heat stress. And then on the right there, you'll see thermosensitivity. So if you remember, that is the slope of the line between when you start sweating and your max sweat output. There was also no differences in thermosensitivity across placebo and drug trials. Having a look at our whole body sweating. So we've broken it up into steady state and non-steady state. So non-steady state would be when sweating is just being activated, so the first 45 minutes of exercise, whereas steady state would be when sweating is already engaged and it's relatively constant. and that would be the last 15 minutes of exercise. And collectively, you can see that there was no differences, no significant differences across placebo and diphenhydramine trials for either steady state or non-steady state whole body sweating. This next one's a little bit busy, but I'll go through them here. So on the left, we can see there was no change in our rectal temperature across placebo and diphenhydramine trials. However, in the middle there, you can see that we did find a significant difference in skin temperature from placebo to diphenhydramine trials. The diphenhydramine condition was seen to be approximately 0.2 degrees Celsius higher, so very small. However, sorry about that. Headset keeps cutting out. But yeah, so quite small. Could very likely just be due to noise or some type of measurement error. And then lastly, there our local sweat rate. You can see that there was no differences observed. So how our participants perceived their heat stress. So we have thermal sensation, quite literally, how hot do you feel right now on a 4-point scale? And then on the right, we have thermal comfort. So how uncomfortable do you feel in this heat? Once again, on a 4-point scale. And you'll notice that for both of them, there was no differences across diphenhydramine placebo trials. So in conclusion, collectively, the oral consumption of diphenhydramine demonstrated no measurable effect on core temperature, sweating, or the perception of heat stress during 60 minutes of exercise in a warm environment. So in other words, next summer when you're outside sweating over some yard work and your eyes are all puffy and you can't stop sneezing, I probably wouldn't think twice before grabbing your Benadryl. And just some future directions for research. So we're still not sure how will these results differ under a more aggressive heating protocol. So participants in our trial were able to reach a steady state, a balance between their heat production and their heat dissipation. What if we just kept heating them up? Right, so really sort of mimicked a more extreme heat exposure, might change our results. Would a stronger dose of Benadryl or maybe a different type of antihistamine elicit the same results? We can't say for sure. We aren't sure if our results are generalizable across different ages, conditions, or geography. So as I mentioned in our inclusion criteria, we were healthy young adults, obviously only in Thunder Bay and otherwise healthy. And then we didn't have any insight on our cardiovascular responses to heat stress. So right at the start of this talk, I mentioned cutaneous vasodilation. We're not sure if there's any changes in that, heart rate or blood pressure. And then so lastly there, we're still not sure, this is quite a big one, if these results would be different amongst individuals that are actively experiencing symptoms of allergic rhinitis. So our trial was our trial was prophylactic administration. So we gave antihistamines to a person that wasn't experiencing symptoms of allergic rhinitis. We can't actually extend our conclusions to non-prophylactic administration or individuals who are suffering symptoms of allergic rhinitis and then decide to take an antihistamine. But yeah, that's the conclusion of my presentation. I have some references there, but I'll keep this open just in case someone has a specific question about a slide.
Thank you, Dougie. That was an interesting walkthrough on this study you've got going. I am wondering, given that this goes like against what the current recommendations are, like it was a small study, so I just how are you feeling about the power that you achieved on your statistics and whether like what else would have to be done before we would start to see some movement on maybe existing guidelines regarding that medication?
So how confident I am? So actually right now I'm working on my master's thesis that we sort of took another step towards having more conclusive evidence we decided to use a more aggressive heating protocol. So we obviously wouldn't want to make any recommendations outside of exercise in a warm environment, right? So I'm just remembering Dr. Dorman's chat about like schmelting or anything like that. We wouldn't be comfortable extending our results to anything like that. But and then obviously the only antihistamine that we can speak to would be Benadryl at this time. In my thesis that we're working on right now, we've included Arius, which I think is desloratadine, and Claritin, which is loratadine. So hopefully we'll be a little bit more confident after that. But as of right now, you're absolutely right in that we probably don't have the power to overturn any, public health guidelines.
Excellent. I'm glad to hear that you're going for some of those common ones that you can get over the counter too. You don't even need a prescription for the Claritin and Arius.
Mm-hmm.
Yeah,
Mm-hmm.
and people probably often have them
Yeah.
available. The difference on the skin temperature was particularly consistent. I know it wasn't large, but
Mm-hmm.
it's consistent and it's there. Do you want to speak to that anymore?
Yeah, it was a quite interesting finding. So I had a chance to present this in Denver, and sort of just through the interactions that I had through that, and we have some cardiovascular data that we didn't present in this. To me, it just kind of screams systematic error. The devices that we're using, they could have been hotter when we put them on, just because it, like you said, it's consistent the whole way through. And so we had that difference at baseline and relatively a similar difference throughout the entire trial. I think it's just some sort of noise measurement error. Yeah, I'm not sure.
There's no physiological reason why the
Well,
Benadryl.
uh, yeah, our only sort of thought process would be that it could have um, impacted skin blood flow, right? Which would obviously have an increase on skin temperature. But looking at sort of the results of other studies and just the information that's available in other literature, it just wouldn't be something that it would just be more likely that it's probably an error. It would be pretty surprising if we actually did find a difference.
Excellent. Okay, I've sort of monopolized the questions, but I don't think I saw any others in our chat or our Q&A. But if you do have something for Dougie, we have about a minute left before we are headed towards a quick break. And yeah, I guess seeing none, I'm going to thank you, Dougie, for that introduction to this area of research. And I think we're looking forward to the work that you'll come out of your master's. So perhaps another year we'll see the conclusion to all of this work.
Oh yeah, thank you, and thank you to the Center for Research on Occupational Safety and Health for having me. Yeah, this is great.